So, what happens when your own body declares war on itself? Today, we're going to put on our detective hats and solve two real-life medical mysteries, piecing together what's known as the autoimmune puzzle. When a patient comes in with a really confusing set of symptoms, doctors don't just, run a bunch of random tests. They become detectives. They start piecing together clues from the patient's story, a physical exam, and, of course, lab results, all to uncover what's really going on.
The cases we're digging into today are all about autoimmune diseases. And a great way to think about it is like a civil war that's broken out inside the body. For reasons we don't always understand, the immune system just gets confused and starts attacking its own healthy tissues. We're talking everything from joints and skin to the brain itself.
So this means the doctor basically becomes an autoimmune detective. They're on the hunt for very specific patterns and clues that reveal which part of the immune system has gone rogue, and more importantly, how to stop it.
To see exactly how this detective work plays out, we're going to examine the files on two very real, very different cases. We'll follow the evidence step by step and see how it all leads to a single critical decision on treatment.
All right, let's start with our first case. I'm calling this one a deceptive arthritis because, as you're about to see, the initial clues were pretty misleading. Okay, here's our first patient file. We have a 34-year-old woman who has been suffering for almost a year with painful, swollen joints. A couple of crucial clues really stand out here. She's a longtime smoker, which can seriously supercharge inflammation. And the standard go-to drug, methotrexate, hasn't done a thing for her. The initial approach has completely failed. So the investigation has to go deeper. The lab results are where we'll find our next set of clues, and they're going to force a really tough choice. Now this is where it gets really interesting. Look at those top two results. The classic antibody markers for rheumatoid arthritis are both negative. That's the deceptive part. But then look at the bottom two rows. Her inflammation markers, the CRP and ESR, are absolutely off the charts. It's like a giant flashing red light, screaming that a major inflammatory fire is burning somewhere in her body. All of this points to a diagnosis of seronegative rheumatoid arthritis. It presents like RA, it feels like RA, but those typical antibody clues, they're just missing from the blood work. This forces the doctor to rely on the physical symptoms and those sky-high inflammation markers to solve the case. So, here's the big decision. The first drug failed. The lab tests are tricky. What do you do next? Do you try another conventional drug combination, add a steroid just for the symptoms, or is it time to escalate to a more powerful, more targeted therapy? The correct answer here is C, start adalimumab, a powerful drug known as an anti-TNF biologic. But why this choice? Well, adalimumab is a modern therapy that precisely targets a key inflammatory chemical called TNF, which is a major driver of joint destruction. After the first drug failed for 6 months, guidelines say it's time to escalate. And given her aggressive disease factors, the goal isn't just to manage her symptoms day to day, it's to get ahead of the inflammation and prevent permanent, irreversible joint damage. The other options are, well, they're simply not aggressive enough. Adding other conventional drugs is just way less effective at this stage, and just increasing the dose of a drug that has already failed, that's really unlikely to work. And steroids, they're just a short-term patch for the symptoms. They do nothing to stop the underlying damage. All right, let's move on to our second case. This one is completely different. It's not a slow, deceptive burn like the first one. This is a sudden, widespread attack happening on multiple fronts. So here we have a 26-year-old woman, and over just 3 weeks, she develops this whole host of symptoms. Fevers, joint pain, a classic rash on her cheeks that gets worse in the sun, mouth sores, and hair loss. But the most alarming clue is the last one, sudden confusion and agitation. The attack isn't just on her joints or skin. It has reached her brain. This changes everything. The situation is no longer about long-term management. It's about a rapid, urgent response to save her organ function. Now, unlike the first case, these lab results paint a crystal clear picture. The positive ANA and anti-dsDNA are textbook markers for systemic lupus or SLE. Her complement proteins are low, which means the immune system is in total overdrive, just consuming them in its attack. And the urinalysis and brain MRI confirm the worst. The attack is targeting both her kidneys and her brain. This leads to the diagnosis of neuropsychiatric SLE. This is one of the most severe forms of lupus. That civil war we talked about is now being fought in the central nervous system itself. And that is an absolute medical emergency. So again, the doctors are facing a critical choice. But this time, the stakes are so much higher. With the brain under attack, what is the single most important first move that you have to make right now? The only correct first move is A, start high-dose IV methylprednisolone immediately. So why this, and why so urgently? Look, when the brain is under attack, you have to put out the fire immediately. High-dose IV steroids are the fastest, most powerful way to shut down that widespread inflammation. All the other treatments can wait. This is the one move that can prevent permanent brain damage. So if we pull it all together, what have we really learned from these two cases? Well, it's about treating the patient in front of you, not just recognizing a pattern in a textbook. And this really is the core lesson. In the first case, the clues were subtle, and the treatment was a very strategic escalation. In the second, the clues were obvious, and the situation demanded an immediate, powerful response. The key takeaway is that treatment is absolutely not one size fits all. It has to be a personalized strategy based on the unique evidence each and every patient presents. And this really leaves us with a fascinating question for the future. We've seen how doctors use these clinical clues, but as we unlock brand new ones, like specific genetic markers, how much more precise is this detective work going to become? It's really something to think about. Thanks for joining our investigation.